The benefit of this is not only for county jails, but for juvenile facilities. It's important to know that as a county, a lot of you spend a lot of money on juvenile facilities and the adult jails. And so let me talk a little bit about sort of the hope of the 1115. As Dominic said, it's meant as a demo, but often the word demonstration makes it seem like a fad, right? It's going to go away. Don't view it that way. As Dominic and Sam and I know, if it's successful, and it will be, and the county's been doing this stuff for 30 years. You're now going to get a new partner, I guess, a Medicaid partner. So it's important to realize it's a stair-stepping towards a permanent part of the Medicaid system, and maybe even expanding. I mean, my hope is someday that 90-day limit, I'm sorry, I should back up. The waiver that's being built is 90 days pre-release. Now in the jail, try to guess that, right? I mean, if you know how to run a jail, it's kind of hard to tell because jail terms can be pretty squishy at the end. So for some people, it's upon entry to the jail will be their 90 days, and that's what I think a lot of jail administrators are looking at. Let me talk about the as-is state. As is now, as Dominic, I'm going to echo some of the point that Dominic made, and I can just speak for the mental health side, which means mental health and substance abuse treatment. A lot of jails do some really good work, but they're using a lot of county money to do it. And those counties who have passed millages are using a lot of millage money to do that, specific mental health, public safety millage. And so this would reduce that burden. In fact, it may eliminate that burden. It may actually allow you to use that millage dollars or those county dollars to provide community-based care. It may allow you to also pave roads, which I hope you don't do with it. Paving roads is important, but it'd be great to keep it in the behavioral health space. So the as is that there's a heavy cost to counties, and Mike Cox a couple of years ago said it's a county obligation, but it'd be great to reduce that by picking up the Medicaid costs. A lot of folks arrested either were on Medicaid or can get on Medicaid, and that's what we want to try to make sure that they're on. The second, I think, negative that's happening now, the behavioral health in jails, some of it's good, some of it's not so great, and you guys know that because it's expensive. I'll talk about what we hope will happen from this. As Dominic said, there's a lack of coordination often, that if the client was a CMH client and they lose that connection because they're on Medicaid, often they'll get a clinician in the jail. Now, they might be a CMH clinician. Sometimes they are. The counties pay for that. Sometimes they aren't. And then you get that disjointed care. So if I'm a Medicaid enrollee in the community getting evidence-based practice, and I get in jail and I'm getting not so much evidence-based practice, my treatment regimen will decline, and so will my health level. And so when I get out, I'm in worse shape than when I went in. The fourth problem is Dominic said, a lack of record-keeping coordination, that often the medical record in the jail, and not always, if you have hired a CMH, you're using the electronic health record they use, but in many times that's not what's being used. Nothing wrong with that except there's no coordination, so that when they go into jail, it's a blank slate. When they leave jail, it's a blank slate again. And the last is that the negative is there's a drop-off in treatment. Either when the person goes to jail, there's a drop-off, or they've never been in treatment before until they get in jail. Often we discover people who need behavioral health because we have arrested them. And then the care gets good, but then they leave jail and we lose track of them again. So it'll stop all that. So here I think there's about 7 or 8 desired states that'll happen from this. The first one is it'll reduce dramatically county expenditures in this area. It'll improve the quality of care. As Dominic said, Medicaid has some pretty high standards. In fact, it may sound odd, I tell people this all the time, the best mental health care in Michigan is in the Medicaid system. They use the most evidence-based practice, or 12 evidence-based practices we get now. The range of care is everything from office-based psychotherapy and psychiatry to drop-ins to residential care to outreach to case management. So it's really a very broad range. Same true on the substance abuse side. As Dominic said, Medicaid-assisted treatment, which is, to use the nomenclature you might be familiar with, methadone programs, or what's called Suboxone, or Vivitrol, really high-end, really great treatment that really keeps people who are opioid addicted sober, and then go back to work, they can stay sober, they can stay out of trouble. That isn't available in the Medicaid program, and as Dominic said, it's a standard of care. So what you're going to get in jails is high-end, evidence-based practice, behavioral health care provided by the Medicaid system. Third is access to the clinical record. So if you do hire the CMH or if the CMH comes in actually, and you don't have to hire him at all, because Medicaid pays for it, you'll get the same kind of care and the clinical record. So if I'm that clinician working in the jail, I can say, yeah, here comes John Smith. I saw him in the community, or my organization did just last week. He's now in jail. I can continue the care he's getting. His record comes over. In fact, the CMH could invite in the same staff to continue care if it's a relationship-based care. Fourth, it eliminates that drop-off. So if I'm getting methadone, or if I'm getting psychotherapy or psychiatry, or if I'm getting case management in the community, and I get arrested, I can then continue that care in jail. In fact, we've always said, it's a very false barrier that says, I'm now behind bars and I lose all my access to the health care I was getting before. I mean, philosophically, I think most Michiganders don't even know that that's true until they or their loved one gets arrested. And then they realize, holy smokes, what was keeping him stable was his or her behavioral health care supports. And now they're gone, and they're gone from that. As Dominic said, some jails don't allow certain medications in. And certain of those medications are vital to retaining stability. And in fact, without those medications and treatment, you know what we have. We have greater incidences in jail, greater incidences of violence or depression or anxiety or suicide. And none of those are the outcomes we're hoping for when we incarcerate somebody. So that's the other benefit. We have reduced incidents in jail. In every jail that we've seen across the country and in Michigan where the mental health treatment is robust, the number of incidents of suicide and violence go down.